Cancer Center. So I trained in psychiatry at NYU, and then last year did a pain and palliative care fellowship at Memorial, and then was lucky to be able to come over here and work in your department and in psychiatry at the Cancer Center. So I'm going to speak on these two topics, specifically with respect to palliative care, although, I think it's going to be helpful for you guys to just learn about some of the basics of diagnosing and treating, basically, depression and anxiety in general, and, some of the literature that's been reviewed in the palliative care setting, specifically about, the epidemiology and some of the nuances with respect to palliative care patients. A lot of the work has been done in cancer for palliative care. Oh, I have to view slideshow, right? Thank you. Okay. So, as I said, these are a few of the major issues in psychiatry, in palliative care, and I'll be just talking about anxiety and depression. I think you guys are having or have already had another talk on delirium and management. Psychiatric disorders are associated with physical debilitation and advanced disease, as we know. Psychiatric disorders are, in palliative care, most prevalent among cancer patients with pain and men with AIDS, although this, I think, was done earlier, and I don't think there's been as much research, but I'm sure it's prevalent in women with AIDS as well. This is important for everyone to know that psychiatric complications are not normal in advanced illness. That being said, obviously, it is helpful sometimes to normalize changes in one's mood or anxiety level at various phases of illness, because certainly dealing with diagnosis and different stressors that come over the course of one's illness leads to symptoms of depression and anxiety. But the point is that you shouldn't just blow off psychiatric symptoms as normal and not help explore them and manage them appropriately. So this is just some of the prevalences of depression in various chronic medical conditions. You see it's highly prevalent depression in both palliative care inpatients and outpatients with cancer. Depression is actually the most common psychiatric disorder in palliative care. The prevalence has been quoted in cancer patients between 5 and 15%, but having major depression, but then another 10 or 15% have sort of subsyndromal depression. The reason why it's kind of a wide range and vague is because the measures that are used aren't always just the structured clinical interview that diagnoses that uses the sort of stringent criteria of the DSM, but rather uses some self-report measures which have a varying level of symptomatology that meets threshold for criteria for whatever they're researching. And also, some of those scales have, a mixture of depression and anxiety, and sort of meld those two concepts into one basic concept of distress. And so the prevalence varies depending on which measure you're using. In the general population, basically the 1 month prevalence, just to get an idea of depression, is sort of between 1 and 4%. Some studies say 1.6% to 4.9%. It's generally twice as common in women, 4.4% in women or 2.7% in men in one study. The lifetime prevalence of depression is between like 10 and 20%. Some studies say 10 to 25% in women and 5 to 10% in men. Though there are some new studies, again, that new epidemiological studies that show that depression, in fact, is more prevalent than we had originally thought with some of the bigger, larger scale epidemiologic studies, that in fact perhaps it's as high as 25% in women and 14% in men. And again, it's very variable in cancer patients. The reports can be anywhere between 1% and 40%. Again, it's related to not just the measure that's being used, but also sort of the center where the study is being done, because if it's a highly tertiary level treatment center, you might find patients who are at further along in their disease, at more advanced phases of illness, when we know that sometimes depression is more severe. So one of the big topics is that depression is highly underdiagnosed in the primary care setting and in the palliative care setting, even though we know that it's highly prevalent in cancer, more so than the general population. One study, for instance, quotes that only 3% in a primary care setting, or 3% of cancer patients were diagnosed with cancer. So some of the reasons are that some people think, or some clinicians might think, that it's, as I alluded to before, that it's an appropriate reaction to illness circumstances. So they might not choose to treat depression or depressive symptoms because it, interferes, the idea that it interferes with the natural process of coming to terms with death and dying. Also, some people think that, well, almost all dying patients are depressed. We see many times in the course of one's illness, especially at the advanced stages, that patients might experience sadness or fear or tearfulness. And so because you see those things, people say everyone has depression, and so the significance of depression at the end of life is minimized. But not, even though it's highly prevalent, certainly not all patients with terminal illness are depressed. And the other thing is that those who are can be helped. Some of the other reasons are that clinicians are not happy or pleased or comfortable with the treatment options. They perceive that some of the pharmacological options are not tolerable, that the side effects are not worth the risk, especially with some of the older drugs. But psych drugs have the stigma or some of the valid sort of attribution of being dirty drugs. Certainly, some of the newer ones address that issue, but they are still, certainly affecting your brain and hit multiple receptors. So there is some validity to that concern, but also. Psychotherapy in itself is something that that still remains less validated in the palliative care setting, although that's changing, and it requires a high specialization. So these things may impede a clinician from being willing to
Would you just go back on the slide for a minute? Because I think it's really impressive, the percentage of depression in non-cancer illnesses.
Yeah.
I mean, in some instances, it's higher than in cancer.
As it's quoted, yeah.
Yeah, that's amazing to me.
Yeah.
I don't think we pay attention.
Yeah, I mean, and I think that, a lot of them are, certainly cardiovascular disease is, that's something that's being studied and gaining ground in the literature about, post, this isn't even with palliative care patients, with post-MI depression. It can be really addressed if you start an SSRI very early in the course of treatment. It's something that cardiologists have to start paying attention to. I mean, in kidney disease and in dialysis patients, it's something that's well known and observed in these chronic diseases, and Parkinson's disease as well. It's sort of part of the late stages of the illness itself. So yeah, it's something that we have to pay attention to.